This conference will now be recorded.
Right. So 14-year-old female presents with anemia, jaundice, right hypochondrial pain. On examination, the vitals are stable. There is pallor, there is icterus, there is splenomegaly. The ultrasound shows cholelithiasis. That means there is a gallbladder stone. The lab values shows elevated LDH and serum bilirubin. The peripheral smear shows, that will be in the next picture. Read the case again. 14-year-old female presents with anemia, jaundice, right hypochondrial pain. On examination, the vitals are stable. There is pallor, icterus, and splenomegaly. The ultrasound shows cholelithiasis, that is, there is a gallbladder stone. The lab values show elevated LDH and serum bilirubin. The peripheral smear shows this. See the peripheral smear and give me the diagnosis. If you know the answer, you can type in the diagnosis. What is the diagnosis, people? Look at the peripheral smear. Type in the diagnosis. Do you want to go back to the previous slide? Read the question again. Read the case. 14-year-old female presents with anemia, jaundice, and right hypochondrial pain. On examination, the vitals are stable. There is pallor, there is icterus and splenomegaly. The ultrasound shows cholelithiasis. The lab values are elevated, shows LDH is elevated and serum bilirubin is elevated. The peripheral smear shows this. So what is the diagnosis? Anyone? What is the diagnosis? Very good. So if the peripheral smear was not given, there's a differential diagnosis that you have to consider. Can be any hemolytic anemia, but because of the presence of splenomegaly, you have to consider the diagnosis of hereditary spherocytosis and autoimmune hemolytic anemia. So these are the two most common hemolytic anemias that present with splenomegaly. All hemolytic anemias have jaundice and anemia, but splenomegaly is most evident in cases of hereditary spherocytosis and autoimmune hemolytic anemia. And splenomegaly plays a major role in the pathophysiology of clinical features of these two diseases. So that is why you have to consider these two as a differential diagnosis. Now, how do you diagnose? By investigations. The other diagnostic tests are osmotic fragility test. Osmotic fragility is increased in case of hereditary spherocytosis. In case of autoimmune hemolytic anemia, the Coombs test will be positive, whereas it will be negative in case of hereditary spherocytosis. Right? So today we're going to talk about hereditary spherocytosis. It's going to be a short class, so pay attention. It's a red cell membrane defect. So we discussed previously about defective hemoglobins. We spoke about sickle cell hemoglobin causing sickle cell anemia. We spoke about the loss of alpha and beta globin chains causing alpha and beta thalassemia. So we spoke about these two. Now we're going to speak about red cell membrane defects. Now there are several red cell membrane defects. The most common is hereditary spherocytosis. The other one is hereditary elliptocytosis. There are other uncommon ones which will also be mentioned in the next few slides. So what are the objectives for today's class? What is spherocytosis? That's what you need to know. What is normal red cell membrane and its function? What is the pathophysiology of hereditary spherocytosis? What are the clinical features and complications of hereditary spherocytosis? What is the diagnosis of hereditary spherocytosis? Differential diagnosis of hereditary spherocytosis and the management of hereditary spherocytosis. So in short, HS, right? So these are the objectives for today's class, and we'll finish the entire class today. It won't take more than half an hour now. Spherocytosis is a genetically determined hemolytic anemia characterized by spherical shaped RBCs. The characteristic appearance is round cells with smaller diameter. So RBCs are normally not spherical, they're biconcave in shape. That gives them a great surface area for the absorption of oxygen into hemoglobin. But now they become rounded with a smaller diameter. The lack of central area of central pallor and decreased surface to volume ratio that is seen here. Normally the surface area to volume ratio is increased in RBCs, and that leads to a much higher area of absorption of oxygen. But here, because of the spherical shape of RBC, the surface area is decreased. Now imagine an RBC which is this shape. If it's biconcave in shape, then the surface area is much more for absorption. This entire area and the ends of the RBC are available for absorption. Whereas if it's spherical and if it's smaller in size, that means the area of absorption will be drastically decreased. And also, if it's spherical in shape, is much more difficult to pass through the reticuloendothelial system. So here's an introduction. Most common hereditary hemolytic disorder. This is the most common hereditary hemolytic disorder of the red cell membrane, hereditary spherocytosis. Mutations of one of 5 genes which are present on chromosome 8 for cytoskeletal proteins. So these are cytoskeletal abnormalities that are produced due to mutation of one of 5 genes present on chromosome 8. The overall effect is spectrin deficiency and is severely dependent on spectrin deficiency. So spectrin deficiency causes the most severe form of hereditary spherocytosis. Just like we have a thalassemia trait, we have a intermediate thalassemia, and then we have a thalassemia major. There is a more less severe form. There's a mild form of hereditary spherocytosis. There's a moderate HS. There's a severe HS and a very severe HS. That depends on the amount of spectrin deficiency. If there are ankyrin or other genes like protein 4.2, if these are band form, these are involved, then there will be a much less severe form of HS. So the incidence is 200 to 300 per million births. It's most common in northern European countries. Underestimated as mild forms are not clinically significant, so they are not usually taken into consideration. The 75% have autosomal dominant inheritance. The remainder have autosomal recessive or new mutations. Subsequently, autosomal dominant inheritance is seen in HS. Here's the normal red cell destruction. RBC completes 120 days of lifespan. After 120 days, there are changes in cell membrane and the enzymatic activity declines. They feed cells less deformable than normal and are recognized by macrophages. So normally RBCs have a good amount of compliance. They are deformable, they can pass through narrow blood vessels being unharmed. When they become senile and aged greater than 120 days, because of the change in cell membrane, the cell membrane permeability decreases, the enzyme activity declines, so there's no protection now. And when they pass through these tiny blood cells, they get more deformed, and that is why they get recognized by macrophages, which leads to phagocytosis and cell death. So that is the normal red cell destruction. Now the red cell membrane consists of 50% of protein, 40% of lipids, and 10% of carbohydrates. And the functions of red cell membrane: erythrocyte membrane, that is normal in structure and function, is essential to the survival of red cell. It maintains stability and normal discoid shape of cell, and it preserves cell deformability and retains selective permeability. Once the red cell membrane is altered, then there is no stability. The surface area of the cell changes. It becomes more spherical in shape. There is loss of cell deformability, which will cause destruction while passing through tiny blood vessels. And selective permeability is lost, so it becomes highly permeable to solutes, or highly permeable to water, which leads to destruction of the cell. This selective permeability loss is the basis of osmotic fragility test in hereditary spherocytosis. Here's a schematic representation of the structure of RBC membrane. You can see there's a vertical interaction proteins and there is a horizontal interaction proteins. In vertical interaction proteins, you can see this is band 3 here, band 3 over there along the cell membrane, and then there's an ankyrin over there which is anchoring to the spectrin protein and the alpha and beta spectrin in the horizontal interaction. There's a protein 4.2 here that is also in the vertical interaction. So band 3, protein 4.2 and ankyrin are the proteins that are here. Whereas in horizontal interaction, there is glycophorin A and glycophorin C. There is alpha spectrin and beta spectrin. There is tropomyosin and tropomodulin. So these are the ones that are seen in horizontal interaction. Now, interactions of RBC membrane, protein and lipids. Vertical interactions are perpendicular to the cell membrane. It includes interactions between skeletal lattice on the cytoplasmic side to integral proteins and lipids of the membrane. It stabilizes the lipid bilayer. So the lipid bilayer is the one that maintains the biconcave shape of RBC. Defects leading to uncoupling of lipid layer from the underlying skeleton. Thus, a selective loss of lipid layer occurs, leading to microvesicles formation. The proteins include ankyrin, band 3, glycophorin, and protein 4.2, etc. Here, you can see in this pathophysiology, there's a band 3 or protein 4.2 deficiency. There's release of microvesicles. These are microvesicles because of loss of lipid bilayer, and then that leads to formation of spherocytes. Here you can see this type of RBC becomes a spherocyte. Here becomes a spherocyte, right? So we'll go back again here. The first one we discussed was vertical interactions. So there's an mutation of ankyrin, band 3, glycophorin, or protein 4.2. In horizontal interactions, it's parallel to the plane of cell membrane. It includes spectrin, head-to-head attachments, and protein interaction at junction complexes. Disruption in these interactions leads to destabilization of membrane, leading to poikilocyte formation. And examples are spectrin and actin. Alpha spectrin abnormalities, it's a recessive inheritance, it's very rare. Beta spectrin, it's a dominant inheritance, it is also very rare. So major spectrin deficiency causes hereditary spherocytosis in the severe form. Ankyrin is a dominant, it is the majority form, it's the form of mild hereditary spherocytosis. Band 3, recessive inheritance, the defect in band 3 will lead to 25% of the cases. So again, spectrin or ankyrin deficiency, again there will be release of microvesicles, again formation of spherocytes. The spherocytes are prone to splenic trapping and erythrostasis. There is decreased pH and increased macrophage contact leading to hemolysis. Further loss of membrane leading to microspherocytes. Again, microspherocytes go through splenic trapping. So this is the pathophysiology of HS. This is a better representation. Here you can see this is the RBC. Because of spectrin, ankyrin, or protein 4.2 deficiency, there will be release of microvesicles. Here it has band 3 in this microvesicles. Whereas if this is band 3 deficiency, there will be release of microvesicles without band 3. There will be a reduced surface to volume ratio, reduced cell deformability, again leading to splenic trapping, erythrostasis in the presence of low pH, high macrophage contact. Low glucose concentration, high oxidant concentration leads to hemolysis, further loss of membrane, and trail of osmotic fragility curve. Here, this is the lipid bilayer that you see, and the smaller ones are ankyrin, these little ones. The horizontal ones or parallel to the cell membrane are spectrin, and these are band 3. So that is the pathophysiology of hereditary spherocytosis. Here you see a little more enlarged version of this. You see ankyrin here, spectrin which is horizontal to the lipid bilayer. You see band 3 that is again vertical to the lipid bilayer, and 4.2 protein here. And this is glycophorin, and actin again which is perpendicular, which is parallel to the lipid bilayer. So this is the lipid bilayer of the RBC. This is spectrin, this is actin, which are parallel to the lipid bilayer, which are in horizontal interactions. There is a band 3, a 4.2, and an ankyrin, which is a vertical to the lipid bilayer, that is perpendicular. There's also glycophorin, which is perpendicular to the lipid bilayer. So any change in band 3, 4.2, or ankyrin or glycophorin will lead to destabilization of the lipid bilayer, leading to microvesicle formation and then formation of a spherocyte eventually because of reduced deformability. And then if there's a deficiency of spectrin or actin, it can lead to poikilocyte formation, which will lead to the early ingestion of splenic macrophage. So this is the normal, this is the abnormal microvesicle formation spherocyte, which is ingested by the splenic macrophage. So what are the clinical features and complications? Hereditary spherocytosis has the same features of any other hemolytic anemia, like anemia, splenomegaly, jaundice from hemolysis or biliary obstruction. It also has hemolytic, aplastic, and megaloblastic crisis because of loss of folic acid. Gallstones are seen here. Characteristically, gallstones are seen. The rare manifestations are leg ulcers, gout, chronic dermatitis, extramedullary hematopoietic tumors, hematological malignant diseases, angioid streaks, neuromuscular disorders, cardiovascular disease, myopathy, and spinocerebellar degeneration. These are rare manifestations of hereditary spherocytosis. The complications are the complications are hemolytic, aplastic, and megaloblastic crisis. So the investigations show a blood film or peripheral blood smear with spherocytes and increased number of reticulocytes. Most of the cells are rounded, spherical in shape, and they may have poikilocytes, and they may have loss of central pallor, and they may also have some macrocytes because of the concurrent vitamin B12 and folate deficiency. There will be elevated bilirubin and LDH. Osmotic fragility test has to be done. Flow cytometry can be done. Gene tests are usually not required. Further studies include SDS page and detects molecular defect of red cell membrane proteins in specific families. It's usually not required, but if it's necessary for any studies, we can do it. So laboratory features are reticulocytosis, spherocytes can be seen, increased mean corpuscular hemoglobin concentration. So MCH will be increased, red cell distribution width will also be increased. Increased proportion of hyperdense cells, increased osmotic fragility, especially after incubation, and negative direct anti-globulin test. If it's positive, that means there is an autoimmune hemolytic anemia. So which other hematological disease do we have? Increased red cell distribution width with low mean corpuscular hemoglobin concentration. So who's going to tell me the answer? Oh, that was fast. Very good. Iron deficiency anemia. That's the right answer. Good job, Deepika. Right. So osmotic fragility test. The principle is when an erythrocyte is placed in a hypotonic sodium chloride solution. So it's not hypertonic, it's hypotonic. That means it has to be a solution less than 0.9% natural saline. That is not natural saline. That is the osmolality of blood. 0.9% saline is the same as plasma. So we have to go for less than that. So hypotonic sodium chloride solution, a net influx of solvent into the cell will occur and the cell will swell. The principle of osmosis you all know. When the two solutions are placed beside each other, water flows from the solution where there is low solute to that of high solute. So osmosis occurs here in the presence of hypotonic sodium solution, and the cell will swell. If the cell size reaches a certain point, the cell membrane will become leaky and hemoglobin will diffuse out, leading to hemolysis. If the NaCl solutions are hypotonic enough, the cell will rupture. The degree of hemolysis can be measured by determining the absorbance of the supernatant using a spectrophotometer. Osmotic fragility. Here you can see the normal one at 1%, at 0.85%. At 1% it's 0 because 0.9% is the natural saline that you see. At 0.85 it's almost nil. At 0.66% it is a little bit hemolysis is seen. 0.5% little more hemolysis, 0.38% a lot more hemolysis, and 0% full hemolysis can be seen. In case of abnormal, the osmotic fragility, even at 0.8% you can see a little bit of hemolysis, at 0.6% a little bit more, and gradually it increases and it goes to 0 here. But you can see a little bit of more hemolysis even at 0.6% and 0.5% natural saline, normal saline. So osmotic fragility graph here, this is the percentage of sodium chloride in the solution and the percentage of lysis here. At 0%, there's going to be a high lysis here. So the normal range is this, whereas in hereditary spherocytosis, it's seen even at 0.7% sodium chloride solution. So even at higher concentrations of sodium chloride, you can see hemolysis. So this is the osmotic fragility. Fragility due to osmosis. It's increased in hereditary spherocytosis. So we have the classification of Hs on the basis of severity here. So I said again, mild, moderate, moderately severe, and severe, or you can call it as severe and very severe. Hemoglobin is normal in mild, in moderate is greater than 80%, in severe it's 60 to 80%, in moderately severe it's 60 to 80%, in severe is less than 60%. That means if hemoglobin is normal is around 15, in severe it's seen less than 9. Reticulocytes are less than 6% in mild, and moderate greater than 6%, and moderately severe greater than 10%, and also severe it's greater than 10%. Bilirubin is 1 point here. It's shown 17.1 to 34.2. That's millimoles here. So normally we talk in terms of milligrams. So it's usually less than 2 to 3 here, and in moderate it's greater than 4. In moderately severe it's greater than 5, and in severe it's greater than 5 to 6. So that's the approximate value. The peripheral smear shows some spherocytes in mild. In moderate and moderately severe, it shows spherocytes. In case of severe, it shows microspherocytes and poikilocytosis. Osmotic fragility in case of fresh blood is normal or slightly increased in mild. In moderate and moderately severe and severe, it is increased. Of incubated blood, osmotic fragility is increased in all cases of all cases from mild to severe. Splenectomy is rarely done in case of mild. They may rarely require transfusions. In case of moderate, if physical ability is decreased, or in some cases they may require splenectomy. In moderately severe, it's necessary at greater than 5 years. In severe, it's necessary at 2 to 3 years itself. So transfusions are 0 to 1 in mild, 0 to 2 in moderate, greater than 2 in moderately severe, and in severe you need regular transfusions. And the sodium dodecyl sulfate polyacrylate gel electrophoresis, right? Sodium dodecyl sulfate polyacrylamide gel electrophoresis. Protein deficiency can be seen. Which surface protein is deficient can be seen. In mild it's normal. In moderate sometimes pectin and chirin plus pectin, band 3 and protein 4.2. In case of moderately severe, pectin and chirin plus pectin and band 3. In case of very severe, it's usually pectin rarely iron plus spectrum, and band 3. Hereditary form is, in mild it's autosomal dominant, in moderate it is autosomal dominant and de novo mutation, in moderately severe it's autosomal dominant and de novo mutation, in severe it is autosomal recessive. So that is the important thing in severe hereditary spherocytosis. It is autosomal recessive. And a differential diagnosis is spherocytes on peripheral smear can be seen in HS, immune hemolytic anemia, acute oxidant injury, microangiopathic and macroangiopathic hemolytic anemias, hemolytic transfusion reactions, thermal injuries, liver disease, Haynes body anemias, hereditary pyropoikilocytosis. Again, this is another form of red cell membrane defect, clostridial sepsis, zinc toxicity, poisoning with some snake, spider, and Hymenoptera venoms, severe hypophosphatemia, long blood storage in vitro, ABO incompatibility in case of neonates, and hypersplenism. So these are the differential diagnosis of spherocytes on peripheral smear. So if you get a peripheral smear of similar thing, you may have to suspect all of these, although the clinical picture can point you more towards any sort of hemolytic anemia. So the treatment for HS is very limited. There's no specific treatment. You give hematinics in form of folic acid supplementation about 5 milligrams per day. Blood transfusion as and when required. Just like, excuse me, just like any other hemolytic anemia, blood transfusion is required whenever there is a need in the form of congestive cardiac failure or in the form of severe anemia, or the patient has physical deficits. And indications of splenectomy are frequent transfusions, poor growth, massive splenomegaly with risk of rupture, and lifestyle limitations. So before splenectomy, you all know that you have to give vaccinations in the form of pneumococcal, Haemophilus influenzae, meningococcal, and pneumonia vaccines. So all capsulated organisms, you have to give vaccinations before splenomegaly, at least 6 weeks before, for 3 doses. And then cholecystectomy will need to be done in case of cholelithiasis, because most of the patients will develop cholelithiasis. Monitor the growth and development. Education and genetic counseling in the form of genogram, likely inheritance and risk to future offspring can be assessed through this. So the last one is hereditary elliptocytosis or pyropoikilocytosis, or South Asian Southeast Asian ovalocytosis. Most forms are autosomal dominant except hereditary pyropoikilocytosis, which is autosomal recessive. The spectrin, alpha spectrin 65% of HE, beta spectrin in 30%, and protein 4.1 in 5%. The HE is incidence is 2.5 to 5 per 10,000 in the US. In Africa or Southeast Asia, up to 30% of the population, they are protective against malaria. Severe hemolysis associated with homozygous or compound heterozygous forms, and clinical spectrum is asymptomatic to life-threatening hemolysis. So that is the brief information about hereditary elliptocytosis. So you can see a peripheral smear which shows elliptocytes here. So yeah, that is the end of today's class. So if there's any doubts, you guys can ask me. If there's no doubts, we'll finish the class.